Hi, it's Jenny B, NSWOC, back today with an episode about pressure injuries. So these are a different type of wound that's caused usually from, you guessed it, pressure. So this happens to patients that have a bony prominence in an area that is under pressure for a prolonged period of time. They can actually happen within a couple of hours, just from sitting on something that's not a supportive surface for them. They commonly occur on the coccyx, on the heels, even elbows, and also in the ischial tuberosities, which is basically your butt bones where you're sitting. So these are ulcers that I'm going to review some of the anatomy of it, some of the devices that we can use to support people with them, as well as some photos that we can talk about staging. Because staging is always a bit of a bone of contention with nurses to make sure that they're staging things appropriately. It doesn't often determine the outcome. The only big piece that we want to know is that we're not going to reverse stage a pressure injury. Once a pressure injury was a stage 4, we don't want to reverse. We're not going to say, oh, now that's healing, it's out to a stage 2, because they've always had that deep tissue loss. So that's just one thing that we want to remember about staging. So I like these lovely anatomy pictures because really that's what your staging is. You're looking at the different tissue types that you're actually seeing as the injury becomes deeper. So when it's at a stage 1, this is the one I always call the pink stage, because yes, it is some erythema, but it's very close to their normal skin color, but there's some redness on top. So it's really the light stage because the skin is intact. But we do know that there is something that's brewing kind of underneath, because they are having pressure to that area, especially if that area becomes non-blanchable, meaning when you touch your finger to the area with redness, if it does not turn white, and that redness stays there, that we do know that they are developing some pressure injuries, and we do want to try to offload them as soon as possible. Offloading is really the key. So again, they may have some edema located in the area. It can be quite painful, and again, we do want to try to rotate them off of this as soon as possible so that they're not developing an actual pressure injury. So again, you're going to see intact skin with a stage 1. With the stage 2, we're getting into the dermal layer. So we would normally in the base of the wound see only red tissue. This is why I call it the red stage, when the skin is actually broken and open, and you're seeing granular tissue within the base of the wound. So this is again the stage where we really, if we can take preventative measures, that's where we want to try to intervene before we get into some of the deeper underlying tissues. Now, if there is a skin tear, sometimes these are confused with a pressure injury. Tears are a little bit different. They're usually just the top surface layer of the skin that happen when a patient has a really fragile skin because they've had long-term steroid use, or again just with age as we start to lose some of our layers. But those again are not considered pressure injuries, and there's a whole other scale and system that we'll talk about in a later video for that. But just to bear that in mind. So your third layer is where you're actually getting into the adipose tissue. This is probably the biggest, the one that people have most difficulty identifying, basically because sometimes you see a bit of red, but it's not that deep. And again, really depending on where it's located, some pressure injuries can be this deep, where others are this deep and still be at a stage 3. It really depends on how much adipose tissue that it's got into and where they're located on their body. Usually on your bottom, it's a lot less than say on an elbow. So again, if you're seeing yellow tissue or devitalized tissue within it, that yellow is usually devitalized adipose or fatty tissue. So whenever you're seeing fatty tissue, you're going to always stage it at a stage 3, even if there's more granular tissue in a lot of the surrounding areas. It has gone the depth of down to the adipose. So again, that's what your stage 3 pressure injuries look like, and for the most part, I call them the yellow stage. So when you're getting into even deeper structures, when you're beyond your adipose tissue and you're starting to see underlying structures such as tendon, fascia, bone, that's why I call this stage the white stage. If you're starting to see white tissue within it, that again, there's striations on it, which would indicate it's tendon. If it's very rough and you can feel it with a Q-tip, you've actually hit down to bone. That can also be a good indicator that you're down into the deeper underlying structures. stage 4 pressure injuries cost the healthcare system quite a bit of money because they take a very long time to heal. So we do have to look at all the other extrinsic factors, especially diet, mobility, diaphoresis if they're actually, you know, hot, sweaty, and whatnot. That, you know, there are other alleviating factors. Again, nutritional status is usually a really big one, and the amount of protein that they're ingesting, so that we can actually treat this in, you know, looking at the whole patient, not just the hole in them. So stage 4 again is which I term as the white stage, and there can often be undermining or tracts, and sometimes the edges aren't adhered. So an unstageable pressure injury is where there is the complete wound base is obscured by devitalized tissue. So in this one we actually have a bit of necrosis, as well as we do have some devitalized adipose tissue. So this would be an actual unstageable because we really don't know how deep it is. Sometimes our body will actually put these protective eshers on to protect the bone. The body doesn't want a conduit open so that you can have infection get right into the body. Therefore it will dry this out and cause this tissue ischemia to occur. Other times, again, it's just because it's so deep, and the tissue actually died from the inside out, which can happen in a Kennedy ulcer, or sometimes when someone is near end of life, where they're just having something called skin failure, where it's not able to get the nutrients that it once did. So again, an unstageable ulcer is one that, for the most part, we want to look at debridement. My other big piece is whenever you're seeing something on a heel, we also want to try to determine the vascularity of the limb, because sometimes these can actually be related to arterial occlusive disease. So I don't go in and debride these right away until I've been able to, you know, at least get a good biphasic waveform on Doppler, and or an ABPI could be completed as well, to determine that, you know, this isn't a vascular wound in nature, that, you know, this is related to pressure. Now, a deep tissue injury is usually where we're seeing ecchymosis or this purple discoloration. So again, we're stage X, where it's the black stage, because you're seeing a lot of necrosis, or Escher, again, you're just seeing bruising with a deep tissue injury. These quite often actually develop down into a stage 3 or stage 4 pressure injury. So when we do note these, it's something that we really do need to keep an eye on, and do try to offload the patient as best as possible. If not, as I said, they will develop down quite further into the underlying structures. Risks of osteomyelitis are quite common with a deep tissue injury like this, and again, these can also just happen from a sudden impact injury. So a type of wound that, again, that would still be caused by pressure. So some of the devices that you still will see out there in the community that patients do try to use, because again, when you've got a sore bum like the last one, they want to try to sit on something else. What we're not using anymore are these rigid donuts. They can actually cause more pressure as well as tissue ischemia by compressing the area and the area around it. So we, for the most part, have been asking patients to discontinue use if we are seeing them. I still do see egg crate mattresses in and about, and sometimes patients will use on wheelchairs. The big key with a crate mattress is to actually have the tips down. You'll see them here that they're all pointing upwards, and patients think, oh, okay, it's going to float it. It actually works much better if you turn the mattress around and the tips are down. That will actually help to redistribute the pressure. What I use commonly here in the hospital is something called a heel lift boot. I use these because they actually have an exposed heel, which is different than some of the other boots that you will see, the offloading boots that are commercially available. These are probably a little bit more cost effective than some of the other commercially available heel lift boots. And they allow for some better airflow, because one of the worst parts about putting them in a boot when they do have a heel wound is that it can actually create too much heat, and therefore it ends up macerating. So again, just be cautious with different heel lift boots that you may be using, but these are quite common. They're about $50 online if you do need to purchase them for a family member. And they will help to offload, especially when they're in bed. I don't suggest patients use these to walk around, because that's not the purpose of them. They're to actually lift those heels up off the bed if they're bedridden or in bed, the majority of the day. There's also sheepskin booties, which we've used for many a moon. Those would be for preventative, when someone does not have a pressure injury, but they're bedridden or in bed for the majority of the day. This can help prevent, but again, they also create a lot of heat. So please be aware that if they do have a pressure injury, that it isn't always the most ideal type of offloading device for them. If there is something on the lower leg and you don't have a fancy boot like this, honestly, using pillows or a wedge is one of the best things you can use to just get the pressure off and float them. So if I could levitate people, pressure injuries would be a thing of the past. There are special wedge cushions such as this that they can also use. Again, I've seen where patients will put their legs up and then with their knees here and over, but again, have to watch that their heels aren't touching, but that they're actually floating. One of the other pieces that you can use for elbows and heels is a posy. These are disposable offloading devices that can be helpful when the bulky boot is not something that's ideal in the bed, or just extremely uncomfortable for the patient. But again, it works really great on elbows as well, especially when we have an infected bursa. Roho cushion is probably one of the most common things you're going to see that we do use for offloading, especially when someone is in a wheelchair. We've used it for many years with spinal cord injury. It works because all these cells are actually connected, but when we're adjusting the device, we always want it at about half, so the patient actually is floating on the surface. We don't want to overinflate the Rohos. They all come with a small manual pump, and again, when they're sitting on it, their ischium should be sitting about halfway down and sunken into the Roho itself, not on the bottom by all means, but about halfway. So adjusting the Roho is quite important, and again, that it's not overinflated for it to be effective. One of the other key pieces that I tend to use that's pretty inexpensive for patients is a gel cushion. These are available in most medical supply pharmacies that do carry medical supplies for the community. It costs about $40. They're, again, something that they can also, they're quite portable. They have a nice little handle. They can take them and use them in the car. They can use them on a seat, especially if they're sitting in the waiting room for appointments. It just makes them a little bit more mobile, but they're still able to help offload. This little cutout is actually where your bottom goes, so that, again, if there's any pressure to the coccyx, that's where it's going to actually relieve that pressure. And again, that gel helps to help redistribute if it's on the ischiums or anywhere else. In the community currently, we still carry which is called a V4 mattress, which has Roho inserts. So you can either get a full Roho cushion or with these inserts. And again, they do need to be adjusted where they're at half inflation. And they do offer a really great option for offloading devices. The gold standard still remains to be a low air loss surface. Now, I do mention this because, again, for individuals, these are actually quite inexpensive. You can buy a low air loss surface online for approximately $1,000. When we're in a facility, they can get into the thousands, because again, the material on top of them has to be something that we can disinfect with each patient. So again, if this is something for a family member or a patient at home, it is something that they can purchase, and they're quite effective. The downfall of a low air loss surface is that it can be more difficult for the patient to get in and out of the bed with it because of the inflation of it. So just to be aware of that, especially if you're putting it on a bed frame, that it is able to lower down far enough so that they're able to safely get out, because it does add quite a bit to the surface. It's more than what a regular mattress is. So those are the main offloading devices that we can use for avoiding pressure injury, and the biggest one is to try to rotate. Again, there's lots of different overlays, such as gel and full mattresses that are something that can actually go over that. Again, we can look at OHH providing, if they do have in-home home care services. Again, these are also something that you can purchase for a patient, or for a family member, if it's something that they're quite uncomfortable on the surface that they're currently laying in. So this is a deep tissue injury. We found this under a patient who had a Zimmer splint on. The patient was then instructed to have the Zimmer splint taken off, but unfortunately she was then transferred to rehab, and that piece didn't actually get transferred with the care, so the Zimmer splint remained on. When the patient returned back, it's a bit of a blurry photo, you can see that this was then broke down to a stage 4 injury, and the unfortunate piece was the patient ended up with an above knee amputation because they were not able to salvage the limb due to the extensiveness and the infection within the wound. So deep tissue injuries can open to be quite large, so it is something that I always do try to note. So when you do see one, make sure that the healthcare team is notified. So this again is a coccyx ulcer that is healing. This was it looks like a lovely nice stage 2 with red granular tissue within it, but you do see a wee touch of white. So this is something that would have been, if the very first time I'd seen it, if there was nothing, I hadn't known that there was an injury that was deeper, I would have put that at a stage 3. However, this wound was actually a stage 4, and we would continue to call it a stage 4 even though it's looking like it's only a stage 2 ulcer injury. I won't do this one. So this is another one when we see that mixed tissue. So this is the one, as I said, a stage 2 to 3 that often say, oh, I think it's a 2 or 3. It's actually just considered a stage 3. As soon as you see that adipose tissue within the wound, we would call it a stage 3, and it would always stay at a stage 3. So this is a full Eschar or an unstageable pressure injury. And again, this is one that is quite protective of the heel underneath. So definitely one I would try to determine the vascularity of the limb first. Again, just even via Doppler waveform to make sure that they have 2 sounds, a biphasic waveform, before I would consider doing any debridement or hydrating of that. Now again, here's one with that mix. We have some of the unstageable Eschar that's developed on it, as well as some nice red tissue, a little bit of yellow slough in there. So we would still call this an unstageable ulcer or injury because of the mix in tissue that we're seeing in the wound. So that's what I have for pressure injuries today. Hopefully you found it helpful. Any questions or comments, please leave them below. And remember, the best kind of wound is a closed one.